Hey, welcome back. All right, we're going to talk about cardiac infections and inflammatory disorders that can happen within different layers of the heart itself. And so just make sure that you have reviewed the different layers of the heart, and the different structures and valves and everything so that you really will understand what's going on when we talk about these infections and inflammatory disorders. So let's get started. All right, so the first one we're going to talk about is rheumatic fever and rheumatic carditis. I know in your peds class, Miss Terrell is going to talk to you about rheumatic fever, and that's something that's pretty common with pediatric patients, but it also can happen within adulthood as well. And a very serious cardiac disorder that can happen as a result of rheumatic fever is rheumatic carditis. Typically, rheumatic fever is it's a systemic and inflammatory disease, and it typically follows strep A infections. Okay, so if a child has a strep throat that is caused by strep A, then they are at risk for developing rheumatic fever, which then puts them at risk for developing rheumatic carditis. Rheumatic carditis, when you hear the word carditis, that's basically just telling you inflammation of the heart. Okay, so it's an inflammation that affects your heart valves, specifically your mitral valve. It also infects your endocardium, your myocardium, and your pericardium. So it affects pretty much all of those layers that surround and help function the entire heart itself. Okay. The antibodies that are meant to destroy strep A, they mistakenly react just against the proteins that are within the connective tissue within the heart, and it causes major damage to the entire heart. All right, so this is just a picture of the flow of how this happens. So the strep infection starts in your throat. You've got Streptococcus A in your throat. The infection travels down to your heart, infects your heart. Antibodies try to kill it out, but they mistakenly attack your heart itself, and then that destroys all the layers of your heart. So your heart is really in a bad place at this point, right? So vegetations can develop then on your valves. Vegetations, it really is what it sounds like. So basically stuff grows on your valves, okay? So as it's growing, your valves start shortening and thickening and pulling away. The different cusps are supposed to meet together, okay? So a healthy valve looks like this, right? Healthy valve is flat, smooth, meets together in the middle. It opens and closes to release the blood flow through. Whenever vegetations grow, and it's just nasty congestion on it, okay, those valves thicken and they shorten and they don't close all the way. And that makes it hard for the blood to know when to flow through and when to stop. So the blood can flow back and forth a little bit too easily, and it really messes up your cardiac output. You're also prone to more bacterial infections later in life because of having those vegetations. You have grooves within those vegetations, and infections can grow and develop within there. It's very, very scary and not good. All right. Here's pictures of the mitral valve vegetations. Do you see these things growing on here, and it's causing this valve to thicken and shorten? Here you can see it right there as well. Okay. All right, so signs and symptoms of a patient who's got rheumatic fever or rheumatic carditis. They're going to have a prolonged mild fever at first, and then you might start noticing some tachycardia because their heart is not able to just forcefully pump out that blood flow. So the heart has to work overtime to try to get the same amount of cardiac output that it would otherwise in a healthy heart. All right. You also might notice some possible dysrhythmias on your EKG, and you'll be able to recognize those once we really learn how to read an EKG. One of the hallmark signs and symptoms of rheumatic fever and rheumatic carditis is a red spotty rash only on the patient's trunk. Okay, and it's very distinct. You really will be able to tell what it is, but it's a red spotty rash just all over their abdomen. It usually disappears rapidly, but it leaves these irregular circles all over their abdomen. Their joints become swollen, red, warm, painful, and they even might develop some nodules on their fingers and their joints. If their central nervous system is involved, they might develop chorea. Remind me to show you what chorea is when we're in class, but it's spastic, uncontrollable, dancing, writhing-like movements, okay? And every class loves to watch me do chorea because I'm not afraid to show you. It's crazy looking. But it's a really sad central nervous system side effect that can come with rheumatic carditis. The cardiac complications, typically you're going to hear a murmur and you're going to hear a friction rub. Friction rub sounds like squeaky leather, like a rubbing together, okay? And then the murmur is just an extra, like, background noise, okay? I'll try to find some examples of what those sound like to play for you in class. You might develop congestive heart failure if your myocardium fails to compensate for the increased demands of the heart, meaning the heart needs to pump out the same amount of blood, right? So if the myocardium is not able to compensate and be strong enough to force out enough blood, then the patient might eventually develop congestive heart failure. The friction rub, this is like what I just said. It sounds like squeaky leather. And a lot of times people talk about it sounding like a grating or a scratching or a rasping. To me, it sounds really like squeaky leather, okay? I'm going to find an example of it and play it for you. The sound feels really close to the ear when you're listening to the patient's chest over your stethoscope. And you might even not be able to hear their regular heart sounds below the friction rub sound because it is pretty loud. It's usually best heard whenever you listen between the apex and the sternum, but it can be pretty widespread. Whenever I've heard it on a patient, I hear it anywhere I listen, but I guess they say if it's a mild friction rub, you can really hear it between the apex and the sternum. Okay, like we said, the murmur is just an extra sound produced as a result of turbulent blood flow. So it's like a swishing, whoosh kind of sound. Okay, so if you're listening to the heart, you hear like a beat, whoosh, beat. All right, again, I'll try to find one for you to listen to. So diagnostic tests that you can run to try to determine if your patient really does have rheumatic carditis or rheumatic fever. There's nothing that's specific, but as we talked about when we were talking about our labs, the ESR and CRP are some pretty non-specific tests just to tell us if there's any inflammation anywhere in the body. Okay, so a lot of times whenever we're looking at heart infections and heart disorders, we're going to test that ESR and CRP to see if we have any kind of elevation in those to tell us if there's any kind of inflammation anywhere in the body. And that's usually going to signal to us the heart has been involved, but it's going to be more specific when it's paired with an ASO titer. ASO stands for anti-streptolysin. Basically, you probably heard this called in the doctor's office a strep test. Okay, so we're testing to see if the patient has strep. So if they have a positive strep test and an increased ESR and CRP telling us that there's inflammation and they have positive strep, we're going to start assuming that they might have rheumatic carditis. Okay, the EKG and the echo will show some structural changes. And it'll also show us, any kind of, just bad rhythms or anything that are happening as a result of this. To treat it, it varies really based on where the patient is at with this infection. IV antibiotics are pretty standard. Like penicillin is one of our drugs of choice unless they have allergies to it. But if they have allergies, then we can use stronger antibiotics like Zithromax, Keflex, vancomycin. We try to stay away from those as much as possible unless the patient does have some kind of bad reaction to penicillin. All right, just because our bodies can only tolerate so much of these strong antibiotics. And if we give the patient too much all at once without trying other things, then they could end up having resistance to those. And we'll get into, what that means later down the road. But it's just for you to, go ahead and know that first we want to try penicillin unless they're allergic. Aspirin is given to help prevent clots because think about it. If those valves are shortened and thickened and that blood flow is not just rushing through, it's flowing backwards and forwards, and some of that blood is becoming stagnant. And whenever the blood becomes stagnant, the platelets aggregate together, which means they clump together, and you can form clots even within the heart, which is very dangerous because then once they do leave the heart, they go to the rest of the body, and you can cause ischemia anywhere, even back into that coronary blood flow, in your arms, your legs, anywhere, okay, in your brain. It's very scary. So we want to put them on some aspirin just to help thin the blood enough to prevent the clots from forming. We also want to give some steroids to start helping to suppress the inflammation that is within the heart. And surgery might be necessary if they have constrictive pericarditis or damage to the heart valves that the heart can't work through on its own. As a nurse, we really want to monitor them for just therapeutic or adverse effects of treatment. We want to promote rest and a relaxing atmosphere, educate them on the history of rheumatic fever, and just encourage them to take prophylactic antibiotics, especially any time before they take any invasive procedure, including dental work, okay? Because think about it, when you get dental work done, there's little capillaries all throughout your gums, and whenever they're working in your mouth, they're introducing bacteria to those little capillaries. It's kind of gross to think about. But if you take a prophylactic antibiotic, especially if you have a history of rheumatic fever or rheumatic carditis, you're going to prevent any kind of infection from entering your bloodstream that way. Before they have any kind of surgery too, they need to take prophylactic antibiotics because these patients are at high risk of developing further complications and further infections down the road. All right, let's take a break. I'm going to start a new little video about infective endocarditis. I just want to make sure we break this up enough so that if you need to go back and really focus on a certain disorder, you can. So I'll see you back in a minute.